Welcome to Dr. Trainees. I'm Dr. Untara Shaikh. I'm the Program Director at MESMARA USMLE Test Prep based in Atlanta, Georgia. And today we will be discussing the management of tuberculosis. As you all know, it's a very vast topic and I have tried my best to make it as simple as possible. And we will talk in pieces about each case, okay? And I have tried to make a lot of different interactions with drugs also. Let's start. So first case over here that we have is 37-year-old man comes to the clinic due to cough over the last 2 months. Okay, he's coming with cough. On vital signs, we don't see anything abnormal. So what about the presenting complaint history? He said that I have this cough over the last 2 months. Cough is productive, especially in the early mornings, and there is no hemoptysis. On medical, social, and family history, he said nothing is positive except for that he is a smoker. Let's do physical examination. On lung examination, we heard crackles and rhonchi over the right upper lung field. There are no cardiac murmurs, no skin rashes. On chest x-ray, we see upper lobe cavitary lesions. Okay. Now, let's talk about case number 2. In case number 2, we have a 45-year-old man that comes to the clinic because of dyspnea, fatigue, and abdominal distension, early morning productive cough for past 2 months. Now, the difference between these two, you can see over here what we have: abdominal distension, fatigue, and dyspnea. Fine. So vital signs, everything looks normal. So let's talk about to him like what's happening. He said that for past 2 months I have this dyspnea, fatigue, abdominal distension, productive cough, early mornings. So what about his medical, social, and family history? He doesn't have any medical conditions, he doesn't take any medications, and he is a farmer and he has no significant family history. On physical examination, we check his extremities. We see peroral edema. On abdominal examination, because we has abdominal distension, right? So we see increased abdominal girth with free fluid. Elevated jugular venous pressure without inspiratory decline. On chest auscultation, we heard increased heart sounds and an accentuated sound or directly after the second half sound in early diastole. So entirely different physical examination than our first patient. So on labs and imaging, we did the chest x-ray. So we see a ring calcification around the heart and jugular venous pressure tracings showing prominent X and Y descents. On labs, we see positive sputum culture, and acid-fast bacilli is positive also. So based on the clinical features, what do you think it is going on? Over here, we have sputum culture is positive, acid bacilli is positive, right? So this means that Mycobacterium tuberculosis is there. But what about those other signs and symptoms that this patient is presenting with? This is your constrictive pericarditis because of tuberculosis. What is happening? Impaired ventricular filling during diastole. It's the number one cause of constrictive pericarditis is tuberculosis. Why he's having fatigue and dyspnea on exertion is because he has decreased cardiac output. Why do we see elevated JVP, ascites? Because abdominal distension was there, right? And peroral edema, because these are the signs of volume overload. He says that I have lack of inspiratory decline in central venous pressure. That's your Cosmol sign. Early heart sound after S2 is your pericardial knock. Okay, so this is your constrictive pericarditis. So how we will treat them? The treatment of tuberculous pericarditis constriction involves the use of standard anti-tuberculosis drugs for 6 months and pericardiectomy for persistent constriction in the face of drug treatment. The timing of the pericardiectomy is controversial. Some recommend that is for all patients once your anti-tuberculosis has started, and others prefer to reserve the pericardiectomy for selected patients not responding to the initial medical therapy. There have been no randomized studies of the practice of early pericarditis compared with surgery for failure to respond to medical treatment in tuberculous constrictive pericarditis. So basically what we need to do when you have this patient in front of you, we will start anti-tuberculous drugs for 6 months and we will do pericardiectomy for persistent constriction. So if, let's say, we start him with an isoniazid rifampin, okay, and then for 6 months, and after 6 months, if the constriction is still there, then we can do pericardiectomy. So what is our low clinical suspicion? So when you have low clinical suspicion means that let's say their anti-tuberculosis test is positive, okay, and the rest is not. So we have like no treatment is initially needed. It's okay. Then you obtain the cultures. So repeat the evaluation at 8 to 12 weeks means that check their cultures again. So if initial cultures are negative and no change in chest radiograph, choose one of the following treatment options. One more time. If initial cultures are negative and no change in their chest radiograph, so we have 3 different options and we will choose one of them based on the resistance and based on the side effects that patient needs. So treat with rifampin and or isoniazid for 18 weeks, treat with isoniazid for 9 months, treat with rifampin and perenzolamide for 8 weeks. Number 1 in this case is treat with isoniazid for 9 months, okay? Then we have high clinical suspicion. So treat with isoniazid, rifampin, ethambutol, and perenzolamide for 8 weeks and obtain cultures. So repeat evaluation at 8 weeks means do their cultures and do their x-rays. Initial cultures are negative, change the, or there is no change in the chest radiograph or symptoms are there. Initial cultures are negative, radiographic or symptomatic treatment is improved, okay? So what are the patients that we need to treat? The patients who PPD test or tubercular skin test in duration is more than 5 millimeter, okay, means these are our HIV positive patients. They have recent contacts with known TB case, okay. We have nodular or fibrotic changes on chest X-ray that's consistent with previously healed TB, and we have organ transplant recipients and other immunosuppressed patients. So these have in duration for more than 5 millimeter. Then we have in duration for more than 10 millimeters. So recent immigrants, less than 5 years from TB endemic areas, injection drug users, residents and employees of high-risk settings like prisons, nursing homes, hospitals, homeless shelters, okay? Microtubercular lab personnel who was working at the lab, and then higher risk of TB reactivation, like we have leukemia patients, end-stage renal disease patients, and then children aged less than 4 or those exposed to adults in high-risk categories. So if these are the ones, if they have more than 10 millimeter of induration, then you will treat them. If the PPD and TST induration is more than 15 millimeter, all of the one that was in the previous slides plus the healthy individuals, that you will treat them. Fine. Now, what are the 5 components of the D.U.H.S strategy? This is your directly observed treatment. What does mean by that? Means that case detection, government is the one that's contaminated to sustain TB control activities. So you remember we used to have TB centers. This is what it is. So the health personnel is directly observing if you're taking the medication or not, or how is the medication is affecting, okay? So number 1, government commitment to sustain TB control activities, case detection by sputum sphere microscopy among symptomatic patients, self-reporting to health services, they come to you, a standardized treatment regimen of 6 to 8 months for at least confirmed smear positive case with directly observed treatment for initial 2 months, a regular uninterrupted supply of all anti-tuberculosis drug, a standard recording and reporting system that allows assessment of treatment results for each patient and of the TB control program overall. So priority situations for the use of DOT. So which are the conditions that you will be like, okay, no, we have to directly observe this patient. So patients with the following circumstances, like pulmonary TB with positive smears, treatment failure, drug resistance, relapse is there, HIV infection is there, previous treatment of either active or latent TB, okay, they have previous substance abuse is there, they have psychiatric illnesses or memory impairment is there, previous non-adherence to therapy, child and adolescents. So these are the ones that you will go and use the DOT. Why I'm talking about this, because when we will talk about management, this word D or T will come again and again, okay? So what I have done, we have different drugs. So I have divided all those drugs with their functions, okay, and their uses, okay, and their side effects and their dosage also. So let's talk about, so anti-tuberculosis drugs are mainly divided into two parts, right or wrong? Yes, they are divided into two parts. So we have first line and then second line. So first line, we have our isoniazid, rifampin, ethambutol, pyrazinamide, and streptomycin. And then second line we have our now fluoroquinolones, oxacillin, levofloxacillin, moxifloxacillin, and ciprofloxacillin. These are the one FDA doesn't approve, but still we use them. Okay, then we have injectable and then less effective second line drugs that are being rarely used. But if all of those have not been properly used or they have resistance against that, so then we will come to this one, but it's less effective. Okay, number one drug we have over here, isoniazid. In the yellow highlights is the name of a trade company in Europe, Pakistan. So use in preventive therapy and the primary drug for use in the combination therapy for active tuberculosis. So this one is the one, this isoniazid is using it where in your preventive therapy, and the primary drug that is used in combination therapy for active, so active TB and for preventive. Okay, it is also used in combination with rifampin for adults and children aged 2 years or older with latent TB as once weekly DOT therapy for 12 weeks. See that DOT is again coming over here. So what they mean by that now over here, we can use this with rifampin for adults and children. They are aged 2 years, or it can be a little bit older than that if they have latent TB, okay, as once weekly DOT therapy for 12 weeks. In patients receiving treatment for active TB, what we need to do, we need to give them pyridoxine, about 25 to 50 milligrams orally once daily, should be co-administered to prevent peripheral neuropathy. Because what happens, the receptor that where your isoniazid goes and bind, it's going to bind where your B6 needs to go bind. So what is happening, your isoniazid is the one that goes and attaches to the receptor. So where your B6 will go, we will have deficiency of B6. That's why we give them B6 vitamin, so we can prevent peripheral neuropathy and also the incidence of your seizures also. Okay, so we did that, and check liver enzymes because it also causes hepatotoxicity. Okay, now we are using it for active tuberculosis. So what are the doses that we are going to use? Over here, please pay attention because it's a lot. Okay, so we have in adults, and per kilogram we are using this. So 5 milligram per kilogram oral or IM. Max dose that per day that you can use is 300 milligram. Daily as a single dose, or 15 milligram per kilogram max you can take up to 900, 2 to 3 times weekly, giving with other agents. We combine with other agents, okay? What about adult children? 10 to 15 milligram per kilogram orally or IM. Max dose again 300. Daily as a single dose, or 20 to 40 milligram per kilogram max is about 900, 2 to 3 times weekly. This is when the patient is coming with the active tuberculosis, the first case that we had. So the first case that the patient was coming and he had what? The chest X-ray was showing what? The chest X-ray was showing upper lobe cavitary lesions. So when the patient is showing you that chest X-ray, it's an active tuberculosis. In active tuberculosis, the dosage of the patient will be depending on the weight. And what we will do, we will give them isoniazid. Okay, so isoniazid was giving it to him. Then we also use to prevent TB in patients exposed to active disease. Let's say you are working at the hospital and the patient has that TB and you contracted it. So we can also use for that. So on that time, we will give them 300 milligram per oral daily as a single dose for 6 to 12 months. Now for children and infants, we give them 10 milligram per kilogram orally, as a single dose for up to 12 months. See the months, it's a big number over there, okay? For active tuberculosis, we are going to use them with other agents. This is a chart over here that has given you different dosage and what we can use in the kids and what are the differential things. So they said that give 30 minutes before breakfast for 2 months to maximum dose of 300 milligram. We cannot go beyond 300 milligram per day. Okay, makes sense? So this is your isoniazid. That's isoniazid is being used in these conditions. So I really am not going into like, okay, when we did active tuberculosis, so I was like, okay, isoniazid is over here, let's do it. I have divided the drugs like that. Okay, when we will talk about a little bit more, then you will understand where this each drug is affecting. So number one, what we had, the first case, we have active tuberculosis, right? So we have two lines of tuberculosis. Number one, first what we have, isoniazid, rifampin, okay? And the second one, the moxifloxacin and all those are not that effective. So what we do, we start with isoniazid in active tuberculosis along with the other medication. So let's see which other medication. Now we have rifampin over here. Rifampin is used in combination with at least one other anti-tuberculous drug for the treatment of active tuberculosis. So active tuberculosis, we use rifampin, and the other drug is isoniazid. In most susceptible cases, now we are thinking that it can be TB, so treatment lasts for 9 months if the patient's sputum culture result is still positive after 2 months of therapy. Okay, so remember the chart that I showed you over there, we have at 2 months, we are going to do cultures again. If their cultures are again positive, so we will continue for 9 months. So we give them for adults 10 milligram per kilogram per day up to 600 milligram per day orally or IV single dose. And children, we give them 10 to 20 milligram per day up to 600 milligram per day orally or IV infusion as a single dose. Okay, then over here we have our chart that's showing you that what we need to do. Okay, now ethambutol. So what is ethambutol is going to do? Ethambutol is the one that's used in combination with second line drugs for mycobacterium resistance. See that? Second line drugs, like are not the first line, for second line drugs for mycobacterial resistance, when we got the resistance with the frequently used previous drugs like isoniazid and rifampin. Okay, administered every 24 hours until permanent bacteriologic conversion and maximal clinical improvement are observed. Absorption is not significantly altered by food, so it's not like, okay, take with food or don't take with food. Adverse effects for this one is optic neuritis, okay, which is usually reversible with discontinuation of the drug. So during the period when the patient is on a daily dose of 25 milligram per gram, so monthly eye exams are recommended. So what is the ethambutol? It is causing optic neuritis, means color blindness will be there. So for initial TB treatment, we give them 15 milligram per kilogram oral every day. Prior to TB treatment, so before the treatment, they had that, like in mycobacterial resistance, so we give them about 25 milligram per kilogram orally every day. After 60 days, decrease to 15 milligram per kilogram orally. Okay, so for how long we will give them? 60 milligram. Daily administration, so like they said, that decreased to 15 every day, right? So how much it will be? 40 to 55 kilogram patient is if, so 800 milligram. If he is 56 to 75, between 56 and 75, we give them 1.2 gram orally. If it's more than 75, we give them 1.6 gram per orally. So see that these are the ones. So initial TB, when we are using them with rifampin and isoniazid, we will use 15 milligram per kilogram orally, okay? But the treatment that we have given isoniazid and rifampin and the patient is not responding to that, then we will give them 25 milligram kilogram. After 60 days, we will decrease it to 15 milligram, okay? So this is what we do. Twice weekly administration. When we do twice weekly administration for it, the patient who is between 40 to 55, we give them 2 grams. Between 56 to 75, we give them 2.8. More than 75, then we give them 4 gram per orally. And if we are giving them more than 3 times per week, then we will give them 40 to 55 kilogram patient 1.2 gram. 56 to 75, we give them 2 gram orally, and then more than 75, we give them 2.5 gram orally. So this is what we have over here. If we are going to give them daily, so this is according to their weight, the dosage will be. If we are administering this drug twice weekly, if we are administering this drug 3 times weekly, okay? chart over here now. So now we have pyrazinamide. So pyrazinamide is the drug that administered for the initial 2 months of a 6-month or longer treatment regimen for drug susceptible tuberculosis. Treat drug-resistant TB with individualized regimens also, so we can use for TB. We have adults and child. What are their dosage? 15 to 30 milligram per kilogram per day orally, not to exceed 2 gram per day, or 50 to 70 milligram per kilogram orally twice weekly, up to a max of 4 gram per dose, or 50 to 70 milligram per kilogram per dose 3 times weekly, up to max of 3 gram per dose. So it's a lot. That's why I was saying that just bear with me that how we are dividing that. So over here what we have, if we look over here, so we have about dosage, single dosage is about 28, right? So 28 is there. So this is what we are going to talk about, like, okay, if the patient dosage is about 20 to 35 milligram per kilogram, single dose is going to be 28, and we give them orally and daily in 3 to 4 divided doses. Max dose is going to be 3 gram per 24 hours, usually given during the first months of the therapy, okay? Because we don't continue this drug because it has a side effect of hyperuricemia. It increases the uric acid. So patient will come to you with uric acid problems, gout. Now, next drug we have is over here, streptomycin, and is used for treatment of susceptible mycobacterial infections. Use this agent in combination with other anti-tuberculous drugs. So we use them with isoniazid, ethambutol, rifampin. Although the total period of treatment for TB is a minimum of 6 months, okay, when we have active TB, we treat them for 6 months. Streptomycin therapy is not commonly used for full duration because of toxicity concerns are there. So that's why it's not recommended, okay? So when patient becomes after 2 months, 4 months, we will stop the streptomycin. So adjust in how much was the dosage? 15 milligram per kilogram per day IM, up to 1 gram per day. Children 20 to 40 milligram per kilogram IM daily, up to 1 gram per day. So over here we have the routes given. Then we have levofloxacin. Levofloxacin is a second-line anti-tuberculous drug and is used in combination with rifampin and other anti-tuberculous agents in treating most cases of multi-drug resistant TB. So now you need to remember now levofloxacin, when are we using? When we have multi-drug resistance TB, okay? A good safety profile for long-term use among the fluoroquinolones have made levofloxacin the preferred oral agent for treating multi-drug resistant TB caused by organisms they are resistant to first-line drugs, okay? So that this is a good drug for that. So what is the dose that we are going to give them? About 500 12-hourly IV can be given, 380 that perorally can be given, okay? Moxifloxacin is used for multi-drug resistant TB caused by organisms known or presumed to be sensitive to fluoroquinolones, or when the first line cannot be used because of intolerance. So then we are going to use Moxi. So these are the dosage for that. Then we have over here rifampin. Rifampin, this agent is used twice weekly as a part of multi-drug regimen for 2 months during the intensive phase of TB treatment. Then once weekly for 4 months, and along with isoniazid or an appropriate agent for susceptible organism. So this rifampin is the one that also comes in your second line management. So what we do, we are going to use as a part of multi-drug regimen for 2 months during the intensive phase of the TB treatment, and then we use them once weekly for 4 months, and we are using it along with isoniazid or any other drug agent. So it is also indicated for adults and child age 2 or older with latent tuberculosis in combination with isoniazid as once weekly therapy for 12 weeks. It should not be used to treat active tuberculosis, okay? The patients who have HIV infection or they have positive TB cultures after 2 months of the treatment. So now over here what we said that they is a part of multi-drug regimen for 2 months. Now if the culture comes back positive, you are not going to keep rifampin, okay? So in intensive phase, we will give them 600 milligram per oral for 2 months with dose spaced 72 hours apart. Must be given with at least one other anti-tubercular. Continuation phase, we can give them 600 milligram once weekly for 4 months, given with another anti-tubercular also. Then we have over here etuanimide. Etuanimide is a second line drug. Okay, again, these are least likely these are being used, and this is used again, what we are using when your first line, okay, if it is recommended if your first line treatment like isoniazid and rifampin is unsuccessful. It can be used to treat any form of active tuberculosis, and it should be used only with other active anti-tuberculosis agents. So it cannot be used mono. It needs to be used with some other anti-tuberculosis. So how much we are going to give to the patient? 15 to 20 milligram per kilogram per day orally. Initiate dose at 250 milligram per day for 1 to 2 days, and then decrease to 250 milligram twice daily for 1 to 2 days with gradual increases to highest tolerance dose. And we can give them 750 milligram per day average dose, not to exceed 1000 milligram per day in 3 to 4 divided doses. So what is happening? This is your second line drug, and when we are going to give them when your first line isoniazid and rifampin is unsuccessful, okay, and it can be used to treat any form of active tuberculosis but with another anti-tubercular agent, so not alone. Fine. So amikacin is the second line drug that used to treat patients with multi-drug resistant TB or those who do not tolerate the first line therapy. So we give them about 15 milligram per kilogram. Single dose of 15 is given either IM or IV. Cycloserine should be administered in conjunction with other effective TB drugs and not as the sole therapeutic agent. Okay, so again, these are the ones that we are going to give them when these are active ones. Active treatments are not being working, or they have resistance development, so then you will choose these. Okay, they are still available in Pakistan, but we hardly go for these because we are going to cost effectiveness and everything. We use the first line drugs. Okay, so initially we use our 250 milligram orally every 12 hours for 14 days, and then you do 500 milligram divided every 12 hours for 18 to 24 months. See, it's pretty long. And monitor blood levels. Then we have our capreomycin. So capreomycin used only when first-line agents, your isoniazids and rifampins, have been ineffective or cannot be used because of toxicity or the presence of resistant tubercle bacilli. So we give them 1 gram every day, not to exceed 220 milligram. Okay, and then we are going to give them for 160 to 120 days. For maintenance dose, we are going to do about 1 gram IM or IV infusion 2 or 3 times weekly. Maintained therapy is given for 12 to 24 months. 20 milligram per kilogram per day is the max dose. You cannot exceed more than that. Refabutin. So refabutin is used for TB treatment in individuals on a specific IV HIV medication. So people who are taking HIV when rifampin is contraindicated. Okay, and then we are using this drug off label for active tuberculosis. 5 milligram per kilogram is orally given for 2 to 3 times per week, and we need to have other tubercular agent with that too. And then we have one more drug over here, clozapizime, that's are also rarely used to treat multiple drug resistant treatment too. Para-amino salicylic acid, so used for multi-drug resistance, okay, or when the therapy with isoniazid or rifampin is not possible. It inhibits the onset of bacterial resistance to streptomycin and isoniazid. Administer this agent with other anti-tuberculous drugs. 4 gram per packet orally 3 times a day is given. Mix granules in acidic liquid or sprinkle on acidic food. Now, I know it was a lot, okay? Let me summarize one more time before we move on to other things. So please bear with me. So what we had over here, we had our first case, okay? On physical examination, what I saw that over here, this patient has upper lobe cavitary lesions, okay? And he has crackles and rhonchi over the right upper lung field. So this one is your active tuberculosis. For active tuberculosis, we are going to use our first line treatment. That was isoniazid, rifampin, okay, ethambutol, and streptomycin. pyrazinamide, sorry, not streptomycin. Then the second over here, we had our patient that's coming with dyspnea, fatigue, abdominal distension, productive cough that's happening early in the morning, right? And on physical examination, he had pedal edema, abdomen had increased girth, distension was there. We can hear a second heart sound early diastole. So what was the thing over here? It was gram positives, like they were acid fast bacilli positive, there was sputum culture is positive. So that was your constrictive pericarditis. That's because of the tuberculosis. So again, we are going to give them what? We are going to start the anti-tuberculosis, the one that for that regimen, the first line for 6 months, and we will do peridectectomy too. Okay, so this is the baseline for 2 cases that we have been talking about. We haven't moved to other things yet. Okay, now over here, the patients that we need to treat, if the patient, we do PPD testing, right? Tuberculous skin test in duration. So if it's more than 5 millimeter, we have these different scenarios, and we will treat those patients with first line. And then we have over here more than 10 millimeter, we treat those patients also. And if the patient has more than 15, we treat the one combination with 5 and 10, plus if they are healthy also. Okay, then what is DOTS? DOTS is the directly observed treatment. So DOTS is done for what kind of patients? The patients who have pulmonary TB with positive smears, treatment failure was there, drug resistance there, they had relapse, they are HIV patients, and they have latent tuberculosis, or they are using substance abuse, they have psychiatric illnesses, they have memory impairment, or they were not adhered to the therapy before, okay, or child or adolescent. So that's why what you do, we separate them and we keep them in the facility where we directly observe their therapy. So management, what was over here? We have 2 lines. First line, isoniazid, rifampin, ethambutol, pyrazinamide, and streptomycin. Then we have our second line, that's not FDA approved, but we do use in Pakistan. Okay, less effective second line, hardly being used, but I gave you the names, I gave you their when they are being going to use. These are the ones we use when these our first line have been failed, okay, or we have multi-drug resistance, then we are going to use those. Makes sense? And then we talked about where are we using isoniazid, and the dosage that I'm telling you is going to be for every patient, okay, for active tuberculosis or the ones that your pericarditis patients, so we will have same dose. And for rifampin, we're going to have same dose also, okay. Ethambutol, we will have same dose. So what does rifampin causes? Side effects. Rifampin causes the red color or orange discoloration of your tears, saliva, urine, okay. So not to get scared, it will get better when you stop the medication. Ethambutol was causing what? Optic neuritis, okay. So what we do when we start the patient on it, we do weekly eye checkups. Pyrazinamide was causing hyperuricemia, so patient can develop gout because of that. Streptomycin is a very contraindicated drug because they have a lot of side effects with it, okay. So these were our medications that we were using, and the dosage that I have given over here, the dosage are going to be used for every situation, every case. The same dosage will be used. That's why I didn't repeat the dose again and again. Okay, let's talk about our different case over here. So the case is 41-year-old woman presents to clinic complaining of severe shortness of breath, cough, and hemoptysis. So over here what we see, vitals are normal. So history of presenting complaint, she tells you I have severe shortness of breath for past 2 weeks, and cough and hemoptysis is there. Medical conditions, she have active tuberculosis now. Isoniazid, rifampin, ethambutol, pyrazinamide, she's taking those. And father has TB, okay, family history, father has TB also, and she's coming with active tuberculosis also. So on physical examination we had bronchi and the same thing, but you send them for sputum. So sputum has positive acid fast, and chest x-ray shows you upper lobe fibrosis, okay. So this was right now when patient comes to you, you sees them. So after 1 month of follow-up, symptoms have improved and they have negative acid fast bacilli, okay. On labs, we have our albumin is 4.8, total bilirubin 0.9, direct bilirubin 0.2, alkaline phosphatase is 42, aspartate aminotransferase is 75, and alanine aminotransferase is 97. I highlighted that on a purpose, that what's happening over here. Yes, the patient has active tuberculosis. She is taking all the medications, but what is happening on her labs? Why these liver enzymes are higher? Because it's the side effects of your isoniazid. So the medical care for isoniazid hepatotoxicity is essentially supportive, and we need to discontinue the isoniazid and any other potentially toxic drugs and closely monitor the patient. Hospitalized persons who are more severely affected, example with significant elevation of prothrombin time, please do remember that. If prothrombin time is elevated, you need to hospitalize patient for monitoring or potential liver transplantation. Early hospitalization in a suitable institute carries less risk and permits more time to evaluate the patient for transplantation. Care of such patients is identical to that for other causes of fulminant hepatitis. So see, that's how much is dangerous. Admit patients to the intensive care unit if they are lethargic, comatose, or severely acidotic or experiencing refractory seizures. Transfer patients after stabilization of vital signs if ICU facilities or the services of the medical toxicologists or transplantation are warranted but are not unavailable. So consider isoniazid toxicity in patients with unexplained new onset, recurrent, or intractable seizures also. If a seizure are refractory to standard anticonvulsant therapy, then what is happening? Your acute isoniazid toxicity. Remember why? Because your isoniazid is going to bind to the same receptor where your B6 vitamin was binding. So what will cause? Deficiency of B6, and it will lead to seizures, peripheral neuropathy. No activity restrictions are necessary unless the PT level is elevated. Activity often is limited by fatigue. So if they are tired, then you will tell them, okay, you cannot do it. Otherwise, we don't limit them anything. So supportive, check their airway, breathing, and circulation. Discontinue isoniazid. Now second case over here. We have 36-year-old male comes to the clinic complaining of progressive fatigability. So what about the vitals? Everything is fine, right? Okay, good. So what he's telling you that I have progressive fatigability and infiltrative pulmonary tuberculosis we see on chest x-ray. So what that mean by that? So he is having TB, okay? So medical conditions, he got TB, he's taking isoniazid, rifampin, ethambutol, benzonamide, he's a smoker, and there is no significant family history. So they are showing you that over here that he has TB and he's taking all those drugs. So on labs, hemoglobin is 8, MCV is 77, MCHCV is 30%, ESR is 17, serum iron is about 170, normal is up to 50 to 150. Okay, total iron binding capacity is about 280, normal is about 300 to 360. And microscopy, when we did, we see RBCs, hypochromic and normochromic anemia is there. So what is happening? Hemoglobin is 8 and MCV is 77. So is anemia is there. But why this anemia is happening? Same reason. When your isoniazid was replacing the B6 from the receptor, that's why we have this B6 deficiency that lead to sideroblastic anemia. So what we are going to give them? B6. But before you start, like let's say when you are going to give them isoniazid treatment, you will give them B6 with it, because now see what is happening? You will prevent them from seizures. We will prevent them from sideroblastic anemia. Fine. Now if they develop all these things, you will discontinue isoniazid and give them what? B6 also. Okay, are we good so far? Now we have over here treatment of multi-drug resistant. So when multi-drug TB is suspected because of a relevant history or epidemiologic information, treatment is initiated after sputum specimens are drawn for culture and sensitivity testing. However, treatment must be started empirically before culture results become available. Once results are known, the regimen is modified according to susceptibilities. Okay, you should not be waiting for the cultural results. Now, other case we have over here, 50-year-old woman comes to the clinic with cough, fever, and weight loss for past few days. And on vital signs, we see that she has a fever and the rest of the things are okay. So what we have over here, she comes to you and she tells that I have this fever for past few days and with night sweats in the night and then cough with productive sputum in the morning, and I have loss of energy. So what based on this is telling you? That she has TB, right? Night sweats we see, cough we see, productive and loss of energy we see in TB. So when we ask her about her medical, social, family history, she's telling that I have rheumatoid arthritis for a few months. I'm taking infliximab, cough syrup, Panadol, and I don't have any allergies. I'm married and there is no significant family history. So only medical condition that is rheumatoid arthritis, and for that she takes infliximab. Okay. So why she is having those TB symptoms? What's going on? Is because it is a latent tuberculosis. So latent tuberculosis is a state of persistent immune response to stimulation by Mycobacterium tuberculosis agents without evidence of clinically manifested active TB. Means it's there, but it's not showing you the symptoms. Someone has latent TB if they are infected with TB bacteria, but they do not have signs of active TB and they don't feel it. So what is happening over here? This is because of infliximab. If you guys do remember in our joint approach lecture that we talked about with rheumatoid arthritis, if patients are giving infliximab, what infliximab was doing? It was inhibiting your tumor necrosis factor alpha, and tumor necrosis factor alpha is the one that keeps the granuloma intact. Where you have inside the granuloma you have TB, latent tuberculosis is there. Now if we give them infliximab, they inhibit tumor necrosis factor alpha, and that's how the TB will reactivate. So exposure is there, risk factors, latent tuberculosis infection happens, and then active tuberculosis will be there. So what are the recommended regimens for your latent tuberculosis, right? So isoniazid 300 milligram daily for 9 months is going to be given. Isoniazid 900 milligram twice daily for 9 months and administered at DOT. Again, you have to observe them. Isoniazid 300 milligram daily for 6 months should not be used in patients with fibrotic lesions on chest x-rays, patients with HIV infections, or children. Okay. Then we have isoniazid 900 milligram twice weekly for 6 months administered as DOT. Rifampin 600 milligram daily for 4 months. Rifapentine 900 milligram plus isoniazid 900 milligram once weekly for 12 weeks, self-administered or as a DOT. No longer recommended is your rifampin and pyrazinamide daily for 2 months because they increase the liver toxicity, so it's not being recommended. Okay, so what we have on our latent tuberculosis management, we have our isoniazid 300 milligram daily for 9 months. We have our isoniazid 900 milligram twice weekly for 9 months. Okay, we have isoniazid 300 milligram daily for 6 months, and then we have our rifampin 600 milligram. So these are the drug, basically isoniazid, rifampin are the one that we use for our latent tuberculosis. Okay, our next case. A 5-year-old child is coming to the clinic with cough, fever, and weight loss for past few days, and we see temperature over there, blood pressure is normal, is for his age is a little bit higher, respirations and pulse are okay. So what is happening? So that for the past few days, patient comes in night sweats in the night, cough with productive sputum and loss of energy. Same symptoms that we saw in our previous patient, okay? And weight loss is also there now. So medical family history, they said that he doesn't have any medical conditions, he doesn't take any medications, he doesn't have any allergies, but he started school recently, and grandfather has active TB. Okay, active TB, grandfather has it. So what is happening now is active tuberculosis. Right? So management of tuberculosis in children. So this is your child that's coming with tuberculosis. So most children with TB can be treated with isoniazid and rifampin for 6 months, along with pyrazinamide for the first 2 months if the culture from the source case is usually fully susceptible. So this is what you will going to do: isoniazid and rifampin for 6 months, okay, along with pyrazinamide for the first 2 months. For postnatal tuberculosis, What we do, many experts say that because the treatment duration to 9 or 12 months because of the possible impaired immune system in children younger than 12 months. So that's why we do that. Now we have isoniazid tablets. So what we do, these are kids, so how we can give them those? So we crush them, okay, maybe crush or add it to food. Isoniazid liquid without sorbitol should be used to avoid osmotic diarrhea, which can cause decreased absorption. So this is the thing that you will tell your patient's parents. Rifampin capsules may be opened and the powder added to food. If rifampin is not tolerated, it may be taken in divided doses 20 minutes after light meals. Ethambutol is often avoided in young children because of difficulties monitoring visual acuity and color perception. Okay, so that's why we will try to prevent that. Now another case we have over here is 25-year-old woman that's about 20 weeks gestation. 25-year-old woman, 30 weeks gestation, comes to the clinic and she's saying that she has fever for past few days. Okay, we see fever over here. History of presenting complaint for the past few days, again cytonitis, cough, productive, and loss of energy. See, same thing. What is happening? Married and work as a social worker, okay, and father has active TB. Social worker is a risk factor and active TB from father is a risk factor, and she's pregnant. So what we did PPD testing, so it's positive. So what is the diagnosis? Active tuberculosis. But how we will treat a pregnant woman with active tuberculosis? So pregnant woman with active tuberculosis should be treated even in the first stage of pregnancy. Isoniazid, rifampin, and ethambutol may be used. Okay, and streptomycin should not be used because it has been shown to have harmful effect on the fetus. Preventive treatment is recommended during pregnancy also. Okay, so we have like preventive medicine, preventive treatment when we are going to give them. Which woman? So pregnant women with a positive tuberculin skin test, results are HIV positive, or who are a behavioral risk factor for HIV infection but who decline HIV testing. They are telling you that we don't want to do that. Okay, pregnant woman who had documented tuberculin skin test, like see on the previous 2 years, but this was active, so previous 2 years, then you will still do that. Pregnant woman who has documented for previous 2 years and who has a pregnant woman who had increased risk for isoniazid induced hepatotoxicity should undergo monthly alanine aminotransferase monitoring while on treatment. Okay, this risk continues 2 to 3 months into the postpartum period also. So what we need to give them, pyridoxine should be administered to pregnant women receiving isoniazid. So breastfeeding can be continued during preventive therapy. Many experts recommend supplemental pyridoxine for the breastfed infant also. Okay, so women diagnosed with TB during pregnancy are at increased risk for having babies who are of low birth weight and are small for their gestational age. Okay, but preterm was not more common in women with TB. So now we have over here, you have seen that a lot of time patients, what they do, they stop taking the medication. When they stop taking the medication, what will happen? Interruption is in the medication. So most of the time we have to think like what we are going to do if the patient has interrupted treatment. So over here, number one thing that what we have, that interruption in the initial phase. Okay, yes, he had interruption in the initial phase. So what you will do, now you need to look for the duration of the interruption. If it's less than 14 weeks, you will continue treatment. If total not completed in 3 months, we start from the beginning. So if they haven't completed their treatment, so you will restart it. If it's more than 14 weeks, we start from the beginning. Okay, continue treatment. If the total not completed in 3 months, restart from the beginning. But if it's more than 14 days, restart from the beginning. Now one more time, interruption is an initial phase. Now what you will do, yes, it was interrupted, so duration of interruption, it was less than 14 days. You started medication a month ago, whatever, and it was less than 14 days, the interruption was like they taking dose or not taking it. So continue treatment. If total not completed in 3 months, restart restart from the beginning. Okay, whatever treatment they were continue, you'll continue that. But if total not completed, the treatment has not been completed, then you will restart. Okay, now if it's more than 14 days, you restart from the beginning also. So this is what is happening if we have yes, they have problem, they have interruption. Now if the patient comes to you that no, there is no interruption, okay, and planned doses in continuation phase are completed less than 80%. So less than 80% they completed it. So duration of interruption, again you will say that if it's less than 3 months, so continue interruption with or without, if not completed, and start from the beginning. If they said that it has been more than 3 months, so restart 4-drug regimen from the beginning. Okay, that will be your 4-drug regimen will be what? Your 4-drug regimen was your isoniazid, rifampin, benzonamide. So these were your 4-drug regimens. So this is what we are going to do. So at 3 months over here, when we have the duration interrupted, and he has been taking and it's not on the initial phase. So at 3 months, more than 3 months, what we do, we check their smears and cultures, and if positive, check the drug susceptibility results and start the DOT. Means now you will observe them when they take it. Okay, so this is what you're going to do. So follow-up evaluation, sputum specimens for microscopic examination and culture should be obtained from patients diagnosed with TB disease at a minimum monthly interval until 2 consecutive specimens are negative on the culture. It is critical to obtain a sputum specimen at the end of the intensive phase, 2 months, to determine if the continuation phase should be extended. In addition, it is essential that patients have clinical evaluation at least monthly to identify possible adverse effects of the anti-tuberculosis medication and to assess adherence. All patients with TB disease should have counseling and testing for HIV. Based on today's lecture, so what we are talking about, that we had shown you different scenarios that TB can be presented as, and kids, in pregnancy, okay, latent tuberculosis is there, drug side effects, what you need to do in that case, in children, how you will treat them. So the dosage is given with each medication, and that's how you will know. Now in next your question answer session, I will put a chart that will be having the dosage with intensive care unit, intensive therapy, intensive phase, continuation phase. Okay, but meanwhile I wanted you guys to read through it, understand it, and please do this thing. If we have an active tuberculosis, so isoniazid is used, how much? If a pregnant lady is coming, how much is the isoniazid? Is going to be same. So I hope it's easier for you to memorize or remember the dosage. Good luck and happy studying.